Okay, so we are going to discuss basal cell carcinoma, a lump or arm excision biopsy done and shown to report BCC with depth of invasion, deep margin involvement. In this station, you will be shown a skin lesion. So they have told you already that this is BCC, basal cell carcinoma, which is on the arm. And now they will ask questions. This picture. You can say these we have the roll margins and central necrosis or central uh, mm, pearl. So so this is basal cell carcinoma. Describe the lesion. What are your physical findings? So purely papule of central ulcer. So this is purely papule of central ulcer with granulation tissue on the base with rolled inverted edges with the surrounding telangiectasia dilated venules. So you can clearly say this. You can clearly tell from this picture that the margins are rolled and there is a central purely central ulcer or necrosis or granulation tissue with surrounding telangiectasia. So you can see here the erythema and telangiectasia, and this is a purely papule. Okay, so this is the description. Why the surrounding skin is red? Due to the presence of dilated subepidermal blood vessels, telangiectasia, or inflammation and erythema. You know, this is a universal law. When there is an injury, there will be surrounding erythema. So most probable diagnosis is BCC, basal cell carcinoma. Differential diagnosis can be BCC, squamous cell carcinoma, skin TB, actinic keratosis, seborrheic keratosis, verruca vulgaris, and this is can be keratocanthoma. So keratocanthoma is more commonly related to squamous cell carcinoma. So keratocanthoma. So keratocanthoma is also the same thing. There is ulcer with central palatine plug, and then vanishes away. It vanishes away with a scar on them. And some people say that this is squamous cell carcinoma in situ. So natural history of BCC. So it is indolent with slow progression. It takes years to grow. It's very slow, locally destructive but limited potential to metastasize, never metastasize. In comparison, squamous cell carcinoma can metastasize. Okay, so what are the subtypes of BCC? So the subtypes are localized, nodular, cystic, and then we have the nodular, cystic, and pigmented and white, and then we have the generalized superficial, multifocal and superficial spreading, and or infiltrative, morphoic, ice pick, and cicatrizing. So these are the different types. Nodular, cystic variants are the most common for 90%. For example, if they ask you the question that what are the most common or what is the most common type of BCC, so you can say nodular and cystic, which accounts for about 90%. What are the microscopic features of BCC? So the microscopic features, the characteristic findings of, okay, so in microscopy we have the white cells in nests with a single palisading layer. It is only the outer layer of cells that actively divide, explaining why tumor growth rates are slower than their cell cycle speed would suggest, and why incomplete excision lesions are more aggressive. Morphoic BCC, basal cell carcinomas, synthesizes type 4 collagenase and so spread rapidly. So, okay, so what are the microscopic features? So, the microscopic features are that they have a white cells, means oval in shaped cells, and they are like palisading, form layers, and so the outer layer is the only layer which grows or divide rapidly, so that's why they are slow. And I will share a proper picture of it in the channel, and with description as well. And the other thing is that morphoic or the basal cells, they produce collagenase type 4, and so which causes the destruction and the spread. How lymph node spread occurs: permeation, growth of tumor cells along the course of lymphatic vessels, embolization, lymphatic angiogenesis. So remember, we have studied that generally the cancer cells produce vascular endothelial growth factor, so they help in angiogenesis of the lymphatics. Plus there can be embolization, the embolus can spread to the vessels, plus also they can grow along the lymph vessels. Okay, so treatment option for basal cell carcinoma: curettage and electrodesiccation. This is the surgical technique, and we have, okay, so we have surgical technique, radiotherapy, and topical chemotherapy. Okay, wait, we'll come to the description later on. So okay, so among the surgical treatment, we have the curettage and electrodesiccation, scraping away the tumor and stopping bleeding with cautery, and excision with primary closure. Okay, so remember, this is a general rule for skin lesions, especially the basal cell carcinoma, squamous cell carcinoma, that you have to excise them. You have to excise them. For example, this is skin and this is the lesion, then you have to excise them properly. Melanoma, basal cell carcinoma, squamous cell carcinoma, all of these you have to do excision. With excision, there are many benefits. One, that you remove the total cancer. The other, that you have biopsy and you can properly say that okay, this is the specific tumor. Other thing is that you check with frozen section, and you can take the margin if it's incomplete. So curettage and desiccation, breaking away the tumor and then stopping the blood with the cautery, and excision with primary closure. You can excise, for example, this skin lesion, this is skin lesion, you can excise this and then you can close the skin primarily, or you can close with a flap, graft, secondary intention, healing. But later on you have to excise the scar. Excision margin of 4 mm around the tumor is recommended where possible. So usually for squamous cell carcinoma, we need about 4 mm of a negative margin to be enough to remove the tumor completely. Okay, so next we have the since, as we discussed, that this should be primarily closed or with flaps or with, that's why we usually refer these patients to plastic surgeons, so they can do better delete. Cryotherapy with liquid nitrogen, but can't obtain biopsy. So the disadvantage of this is that you cannot obtain the biopsy, so excision and biopsy and still the best. Mohs microsurgery, serial tangential horizontal sections are taken and examined histologically until margins are clear. So this is a gold standard approach either for melanoma and for BCC or squamous cell carcinoma, that you constantly okay, so Mohs microsurgery have some specific indications. In every case we do not do this because this is very you can say expensive. You have to take like sections, and then narrow sections, thin narrow sections, and then you constantly do the frozen sections and check whether the we have clear margins or not. So you do not do this in every case, you do it for specific indications. For example, we have the recurrent lesions or areas of the cosmetic regions, for example face, genitalia, and extremities. So in such cases we do Mohs microsurgery. So what basic concept of Mohs microsurgery is that if you have a lesion, let's suppose you have a skin lesion, so you constantly take sections, horizontal sections, and you check these under microscope, frozen sections, until the tumor is clear. So radiotherapy, you can do radiotherapy, and then we have the topical photodynamic therapy, for example delta or amino levulonic acid made up of 20% emulsion and applied topically. Tumor tissue absorbing with porphyrin metabolite become photosensitive with its conversion to protoporphyrin 9 and subject to photodestruction when exposed to light, usually in the wavelength range of 620 to 670 nanometer. Topical fluorouracil, topical emoquimod 5%. So you can use these agents topically. And here we have the aminolevulinic acid, 20% emulsion. Okay, so what are the advantages of frozen section? So intraoperative diagnosis and quick results, no need for fixation, assessment of margin clearance, so you get the clear margins. Skin graft placed for the patient and subsequently had graft failure, cause of graft failure, so wound infection or hematoma formation. So whenever you put a graft, so here can be infection, so you will lose the graft. There can be underlying hematoma which can dislodge this graft. So common organism for graft infection is the Staph aureus. Wound culture and sensitivity grew MRSA. What is MRSA? Methicillin resistant Staphylococcus aureus. How would you manage this patient with MRSA wound infection? I will also isolate the patient first. Yes, will seek help for infection control team. When consult microbiologist and consultant surgeon. If abscess ID will be done. Oral antibiotics as clindamycin, amoxicillin plus tetracycline or linezolid for resistant cases, and this is for outpatient. You do the ID and give him oral antibiotics. For inpatient, vancomycin dose target trough level is 7 to 14 days, and linezolid 600 milligram twice daily per oral or IV 7 to 14 days. So this is the treatment of MRSA. You can give daptomycin 4 milligram per kg once daily, 7 to 14 days. You can give telavecin 10 milligram per kg once daily, 7 to 14 days. You can give clindamycin 600 milligram IV or 300 milligram per oral 3 times daily. Okay, so this is your treatment. So you also have to do the decolonization with mupirocin nasal or chlorhexidine for body decolonization. So you give him or her mupirocin nasal spray, so to remove this from the nasal cavity, and also you give him the chlorhexidine to take a shower with this, so you have body decolonization. So what we have here, so initially clindamycin or vancomycin IV, if not improved rifampicin, if still not improved linezolid. So this is the algorithm: vancomycin or clindamycin IV, if not improving you go for rifampicin, if then not improving you go for linezolid. After excision, the patient developed regional lymphadenopathy. FNAC was done and revealed lymphocytes, polymorph lymphocytes, histiocyte cells with bilobe nuclei interpret. So this is bilobe nuclei with lymphocytes. So this is Reed-Sternberg cell, OLI appearance. This is Hodgkin lymphoma. Why cytology seems to be inappropriate, inconclusive? Poor technique, so your cytology will be inconclusive or inappropriate if you have a poor technique, especially if not done under image guided, inadequate sample, no information about rearrangement, invasion, lack of differentiation, or has not produced the definitive result. Inflammatory cells may mask the diagnosis. Mechanism of lymphatic spread. So malignant tumors release growth factors such as vascular endothelial growth factor C. They induce lymphatic vessel expansion, lymph angiogenesis in the primary tumors and draining central lymph nodes, thereby promoting lymph node metastasis. So this is all about the this basal cell carcinoma. So you may be wondered that what is this. So this is actually, they are saying that you have taken lymph node FNAC, and now FNAC result is not inconclusive, is inconclusive or inappropriate. So why? Because if you go blindly, you will not get the required result. If you take the inadequate sample or there is no information about the for example, FNAC is a poor technique. You don't know about the background cells, you don't know you can the result can be masked by the infiltration of the inflammatory cells. So always the superior is a biopsy, excisional biopsy.